Welcome back to the deep dive. Today, we are wading into a really fascinating and, frankly, a pretty terrifying topic.
Like,
It's the world of lithium. It's this incredibly powerful medication, an absolute gold standard for things like bipolar disorder, but it operates on a razor's edge.
a complete knife edge. You are always dancing between this profound clinical benefit on one side and severe, sometimes permanent toxicity on the other.
And that's exactly what we're digging into today. Our sources are really pulling back the curtain on the science, how the body handles lithium, and then getting into a major modern debate.
Right, and the boat is this. When toxicity happens, is aggressive intervention, specifically dialysis, always the right move?
Or can it sometimes cause more harm than good? So that's our mission for this deep dive, to really unpack the risk of the lithium level itself versus the risk of trying to correct it too fast. So let's start with the basics, the kidneys.
You have to start with the kidneys. They're doing all the heavy lifting here. I mean, over 95% of lithium elimination happens through the urine. And what's just completely fascinating is the mechanism. The kidneys handle lithium almost identically to how they handle sodium.
A sodium imposter. I love that idea.
That's exactly it. They're similar enough that the body's own systems for balancing salt and water just sort of treat lithium like this unwelcome guest that looks like sodium.
So the kidney filters the blood, lithium's in there. How much of it actually, makes it out versus getting sucked back into the body? Because that reabsorption seems to be the real issue.
It is the engine of toxicity, and a surprising amount gets reclaimed. About 80% of the lithium that's filtered gets reabsorbed, mostly in the proximal tubules, so right at the start of the filtering system.
80%. That seems incredibly efficient. Is the body actually trying to save lithium?
No, and that's the trick. It's basically a passive process.
Yeah.
It's just riding along with the huge effort the body is making to reabsorb sodium and water. Lithium just happens to, sneak along for the ride.
And that brings us right to the core principle of toxicity, doesn't it? If the body thinks it's dehydrated, it goes into maximum sodium-saving mode.
Exactly. And anything that tells the kidneys to hang on to sodium will also make them hang on to that sodium imposter, lithium. And that's when you see those levels just spike.
This has to be critical for understanding why someone who is taking their medication perfectly can suddenly become toxic.
It is. And it leads us directly into the really crucial part for any clinician, which is drug interactions. We found just a handful of really common medications that can drive those lithium levels way up.
Okay, let's go through them. What's on the list?
So the first big ones are the thiazide diuretics. This is pretty straightforward. They make the early part of the kidney hang on to more sodium, and so lithium gets retained too.
Makes sense. But what about ACE inhibitors and ARBs? I mean, those are incredibly common blood pressure meds.
That's a great question because it's a bit more complex. They affect the whole renin-angiotensin system, and the net result is that they change how sodium is handled way up in the proximal tubule.
So more reabsorption up top.
Exactly, more proximal reabsorption, which means more lithium gets reabsorbed too.
Then you have NSAIDs, Motrin, Aleve, things people grab for any little ache or pain.
NSAIDs are tricky. They actually reduce blood flow to the kidneys, and when you slow down the blood flow, you slow down the whole filtration process, which just gives the kidneys more time to suck that lithium back up.
And what was the last one?
Don't forget the antibiotic metronidazole. It's a classic cause, even if we don't, fully understand the mechanism.
That list, I mean, that needs to be on the wall of every clinic. So conversely, what about drugs that actually help clear it?
Right, so things that promote sodium clearance tend to promote lithium clearance. You've got acetazolamide, SGLT2 inhibitors, loop diuretics. They all push sodium out and lithium follows.
Any surprises on that list?
A little one, yeah. Xanthine derivatives like caffeine.
Caffeine.
Yeah. Caffeine can actually increase the glomerular filtration rate. Just speeds up the whole system so you clear it faster.
Okay, so we know how lithium gets stuck. But once it is, and you get that terrifyingly high lab value back, say, 4.4 millimolar, our sources argue that single number just doesn't tell you the whole story.
This is where the art of medicine really comes in. It separates the expert from just following an algorithm. And the sources have this perfect introductory case.
Let's hear it.
It's a 20-year-old man, comes in with a bad viral gastroenteritis, totally dehydrated, and his lithium level is 4.4.
And, okay, based on some of the guidelines we're going to talk about later, that number alone, 4.4, might have triggered an immediate call for dialysis.
It absolutely would have if he'd shown up at a big academic center, but he didn't. He went to a small remote community hospital first.
So they didn't have immediate access to dialysis.
Right. So while they're waiting for transport, all they can do is give him aggressive IV fluids for hours. They basically, without meaning to, performed a therapeutic trial of rehydration.
So the lack of resources actually forced them to do the right first step.
Precisely. By the time he gets to the big ICU, he's already feeling better, he's making urine again, and his repeat lithium level is down to 3.4. That rehydration saved him from a procedure that would have been unnecessary and potentially harmful.
That's a stunning story. It just shows you how much fear is driven by that one number. But you said we need to consider some factors here. Factor one is pharmacokinetics, acute versus chronic.
Yeah, the risk profile is completely different. If your patient takes a massive one-time overdose, a level of 4.4 probably means it's still being absorbed from their gut.
So the level is still going up, that person is in immediate danger.
Extreme danger. But our guy in the case study, he was on his normal dose. His 4.4 was from dehydration. His level was already filling with fluids. Same number, totally different trajectory.
And then there's factor number two, which complicates it even more, serum levels versus brain levels.
Right. The brain is the target organ here. That's what we're worried about.
Yeah.
But lithium takes time to cross the blood-brain barrier.
So the barrier is like a time delay shield.
It is. In a big acute overdose, you might actually be able to clear a lot of the lithium from the blood with dialysis before it has time to fully saturate the brain and do permanent damage.
Which is why aggressive treatment in an acute overdose makes sense. Get it out before it gets in.
Exactly. But in chronic intoxication, where the level has been high for days, the brain has already had plenty of time to equilibrate. The serum level might be coming down, but the brain level is still high.
And even at a steady state, we know the serum level is a pretty poor predictor of what's actually going on in the brain.
It's a very poor predictor. And this leads us to the biggest danger of all when we talk about rapidly treating these chronic cases. It's something called the syndrome of irreversible lithium-effectuated neurotoxicity.
Or silent syndrome.
Silent.
I mean, that name alone is terrifying. It implies permanent damage. What is it?
It is. It's defined as potentially permanent neurologic injury. We still don't totally understand the mechanism, but clinically, you see things like debilitating cerebellar dysfunction, so severe problems with coordination and balance, and lasting cognitive problems.
And the sources really stress this key counterintuitive point. Silent is actually more common with chronic intoxication, not acute overdoses.
That is the insight that should change practice. The thinking is that it might come from these chronic adaptations the brain makes to the lithium, which then get violently destabilized.
Which brings us to the paradox.
The paradox is this. For patients on chronic lithium, dropping their levels really fast, which is exactly what dialysis does, might actually increase their risk of developing silent syndrome.
Wait, hold on. The patient is toxic. The treatment for almost every other poison is get it out as fast as you can. Why would that be bad here? This goes back to the sodium imposter thing, doesn't it?
It absolutely does. You have to remember, lithium acts like sodium. The brain has adapted to a certain osmotic concentration. So when you use dialysis to rip the lithium out of the blood in a few hours,
You're creating a massive osmotic shift.
a massive shift. It's just like correcting a really low sodium level too quickly.
Yeah.
We know that can cause things like central pontine myelinolysis or cerebral edema, catastrophic brain injury.
So the treatment itself, the rapid removal, is mimicking the kind of osmotic insult that causes permanent neurologic damage.
Precisely. And that is the true danger. You might be causing the very injury you're trying to prevent.
That is a huge question. I mean, is there any good evidence that dialysis even prevents silent syndrome in the first place?
There isn't. There's no good evidence that prevents it. In fact, our sources argue it is entirely conceivable that dialysis could actually promote its development by triggering those dangerous osmotic changes.
So if the brain has adapted, hitting the reset button with dialysis might be the worst thing you can do. It's better to let the brain re-equilibrate slowly. This takes us right into the heart of the controversy, the guidelines.
The guidelines are a mess, and that's always the first sign that the evidence is shaky. For instance, a major source like UpToDate says you should do mandatory dialysis for an asymptomatic patient if their level is over 4.
Yeah, absolute number.
An absolute number.
Oops.
Or 2.5 if they have kidney problems. But then you look at the EXTRAP guideline, another big international authority, and they set the threshold much higher. They say 5 or 4 with kidney dysfunction.
The fact that they disagree is the whole point.
It's the whole point.
Mm.
And our sources argue that using any single number to mandate dialysis is, and I'm quoting here, absurd.
And you go back to that first case, the 20-year-old. His level was 4.4, but simple rehydration was already fixing the problem.
Right. Why would you jump to an invasive procedure when just giving IV fluids and watching closely will likely bring the level down below that threshold in a few hours? It's the common sense approach we use for almost everything else, like high potassium. But with lithium, we panic at the number.
So the fear of deterioration drives this push for immediate dialysis, but the data might suggest that action could actually make things worse.
That's the finding from a really important retrospective review from Swartz back in 1994. It looked at patients with chronic intoxication who were still responsive when they came in,
Not comatose.
not comatose. And in that group, the ones who got dialysis were associated with much higher rates of deterioration in the hospital. We're talking 85% of the dialyzed patients got worse versus 46% of the non-dialyzed patients.
That is a staggering difference. The intervention is associated with nearly doubling the rate of getting worse.
And the long-term outcomes were even more concerning. The dialyzed group had persistent neurologic problems at a rate of 62% versus only 22% in the group that was managed conservatively.
Which led to that quote.
While hyperlithemia can be toxic, its rapid correction can be more toxic.
So for a stable, asymptomatic patient with chronic high levels, if their kidneys work, the safest bet is just fluids and watching them closely.
Yes, because their level is likely already falling at a safe, gentle pace. And there's another point here, which is that just abruptly stopping lithium can also be a problem.
Right, because of the underlying psychiatric condition, but also...
Also because that rapid withdrawal itself might destabilize the brain and increase the risk of silent.
They even mentioned a case where they did the opposite, right?
They did. A case where a patient with chronic toxicity was admitted, and counterintuitively, they gave him a little bit more lithium just to prevent the level from dropping too fast while they were stabilizing him.
That's incredible. It just shows how much the speed of change is the recognized risk.
It is.
Yeah.
And this is why the authors are so critical of the guidelines.
Mm.
They argue that these rigid rules just camouflage the real uncertainty. They encourage this paint-by-the-numbers approach instead of nuanced critical judgment.
The evidence just isn't there for a hard and fast number.
Not for asymptomatic, chronically exposed patients. It has to be an individualized decision based on the whole clinical picture, not just one lab value.
Okay, so let's try to synthesize all of this for everyone listening. The core lesson seems to be about balancing two different dangers.
Right. The danger of the high level itself versus the danger of a rapid, osmotically jarring change.
And for that patient with chronic asymptomatic high lithium who's just dehydrated but has working kidneys.
For that patient, conservative management, fluids, and just watching them closely seems to be a much safer, much smarter strategy than rushing to dialysis. It's about being thoughtful, not just reacting.
And as we leave you with this deep dive, here's a final, really provocative thought to chew on. The average lithium level among all the reported cases of silent syndrome, those people with permanent neurologic damage,
Yeah,
that average level was only 2.3 millimolar.
that is a staggering detail. That's a level that is often near or just barely above the therapeutic range.
So what does that tell you? It suggests silent isn't just about massive overdoses. It might be about a unique vulnerability in certain patients, or maybe it's all about the correction. Why is that sudden withdrawal of lithium so destabilizing for some brains, even when the level wasn't astronomical to begin with? Something to mull over until our next deep dive.